You have you all know the drill. We just work you hard this morning so that you're too exhausted for the sessions in the afternoon. We're going to go through 3 presentations back to back this morning before we have a break. But I am really happy now to be able to introduce our first speaker for today, Neal Halfon, who reminded me that we met at a Rockies game. He can tell the story better than I, but that was a great reminder. Neal, I've had the pleasure of working with in a few capacities over the years. He's the director of the Center for Healthier Children, Families, and Communities at UCLA, and is a professor of pediatrics, health services, and public policy. And without further ado, to talk about Health 3.0, please welcome Neal Halfon.
Fantastic. Good morning, and it's a great pleasure to be here with you. And I'm going to talk about 3.0 strategies. And yes, we did jump from 2.0 to 3.0 overnight. So let me, oops, go back. Okay. So what I'm going to do is I'm going to talk about the pressing need to transform our health system. The opportunity, the focusing on children to lead the way is one important strategy. And to talk a bit about the new science and new frameworks that allow us to focus on upstream determinants of health and about life course health development. I'm going to lay out what a 3.0 transformation framework might look like, what 3.0 innovations are starting to emerge, and then if I have time, I'm going to talk about 3 national initiatives that are really focusing on transforming communities so that they can do what Alan was talking about. The Transforming Early Childhood Community Systems Initiative, something called the Child Health System Transformation Initiative, which is about bringing together thousands of communities to really focus on their children's health in a new way. We have a major health policy challenge that Alan has sort of laid out. We have the most efficient, low-value, low ROI health system in the developed world. We have this triple aim of improving population health quality at lower costs, but we have these enormous challenges. We have enormous social and health disparities. We have rapid and rising rates of chronic disease. We have unavoidable demographic shifts, and we have relentless cost increases. And we have an anemic and tired health policy strategy that Alan was sort of talking about that does not reflect what we know about producing health, and it's handing all the keys of the kingdom back over to the healthcare system to solve the problem. And we have an old, outmoded operating system that's mismatched between what our 3.0 aspirations are, our 2.0 goals, and our 1.0 payment methodologies. And what I'm going to talk about is really reframing the narrative and how we think about change, improvement, innovation, and transformation. It's really going from a medical care system, not just to a healthcare system, but what a health system would look like. How we go from mechanical and linear models to more complex adaptive systems models that you heard talked about yesterday. How we go from biopsychosocial models that think about multiple determinants to really about the life course and about how we understand how health develops. About moving from just vertically integrated health systems to horizontal and longitudinal integration so that we can think about the whole person over their lifespan. Moving from thinking about marginal risk of the marginal populations to how do we actually shift the median risk of the population. Thinking about how we go from programs for individuals to systems for populations. How we go from hot spotting and cost control to cold spotting and health development scaffolding. How do we build the infrastructure that we need? And how do we go from the current mismatches to really to alignment and integration? And what I think about when I think about change, I think about different strategies. So we have Fixit strategies where we're thinking about how do we fix the broken parts of the system. We have lots of broken pieces in the system. We have incremental improvements that are evidence-based improvements in services where we add a new screening tool, we add a new program, and they help us move forward in terms of where we're at. But what we really need are transitions. We need jolts and quantum leaps in our system that are really going to come about in new ways of organizing what we're doing. And 3.0 ACOs are health development organizations rather than just accountable care organizations, and there are several others. And the last level is transformation. And I just challenge you to think about what you're doing. Are you just fixing the broken parts? Are you making incremental improvements? Or are you really about transitioning? And when we think about it, what are our bundle payments for care pathways that address upstream social determinants? Is that really a Fixit strategy, or is that a transition? Our cross-sector service pathways, our integrators and backbone organizations trying to achieve collective impact, our data systems that link community health centers with schools and child care, our life course measurement systems that connect our dollars to health outcomes. I'm trying to lay out what are things that are really going to take us in the direction of real transformation. This report that came out from the Institute of Medicine last year was about why the United States is the sickest of rich nations, and it came up with several conclusions that I thought were important. One was about how we allocate our resources. Other nations invest in success. They put much more money into education and social care, and we put most of our money into when people are actually sick. So we pay for failure. They invest in success of their population. We have many more chronic illness, and the rise of chronic illness in our society is actually faster than these other nations. And U.S. children are less healthy and carry a burden with them in chronic illness right from the start. So in thinking about the rapid rise in chronic illness, you're just seeing here the rapid rise in all kinds of chronic illness over the last couple of decades. But I'm pointing out the rapid rise in mental health problems as one of the really important things that I'm going to come back to. And I show you this, which is from the UNICEF report. And let me just take a pause here. Alan showed almost no PowerPoints. I'm going to just overwhelm you with PowerPoints, okay? And all these PowerPoints will be available to you, so you'll have them all. So don't think that you have to get it all. I'm just going to be a lot of flash, sort of concepts here. This is the UNICEF report showing how children are doing around the world, looking at their health, their mental health, and their social abilities. And there's the United States. We're down around 29 of 31 countries. So we have the sickest kids in the world, and that's part of why we have the sickest nation. And part of it is our pipeline is filled with kids right from the start, and we're not paying attention to that. A few minutes talking about that. So we have a real big change in the epidemiology of children's health. We have an increase in the number of kids with chronic health problems, and it's not hemophilia, congenital heart disease, and cancer. What it is growing prevalence of mental health problems and issues like childhood obesity. Right now, 22.8% of adolescents have mental health problems with impairments in the United States, and this is rapidly increasing. We have a greater appreciation for the role of neurodevelopmental problems, and we have a growing number of children with multiple comorbidities, including asthma, obesity, and ADHD. And there's a reason why they're happening all at the same time. Obesity isn't the only problem that's emerged over the last 30 years. There's several others, and we're not paying attention to it. This is a focus on the trends in childhood disability in the United States, and it's showing from 1960 when we had 2% of children with disability reported by the National Health Interview Survey. We're now up to about 8%, and we have a major shift in what disability looks like, but this is steadily increasing in our country. And we look at mental health disorders, and I just show you this, that 70% of all mental health disorders that anyone will have over their lifetime can be diagnosed before someone is 25 years of age. So we have this opportunity, if we're going to prevent mental health disorders, we have to start early and have to really think what the roots of this epidemic is all about. And we know that adversity has a big impact on health, and especially children's health. So adversity and prosperity have dramatic effects on the health development of the population. Adversity comes in many forms, not just economic, but social and time adversity, family and behavioral adversity. We have these things called ACEs that we talked about yesterday, adverse childhood experiences, in a paper we published in Health Affairs in, I think, December. We showed that 44.8% of children have at least one adverse childhood experience, 22% have two or more, but there's a huge social gradient to this, so that and it's not just the poorest kids at 200% of the poverty level, 300% of the poverty level, have lots of adversity in their lives. And the rising rates of mental and behavioral and developmental problems are linked to this rising levels of adversity. And we have over 40% of our children now live in low-income families or in families with a single parent. And families don't have the resources they need to actually have healthy children. And I show you a couple of things that bring this home. From a scientific standpoint, adversity leads to something what we now call toxic stress, in which the chaos and the violence and the other things in their environment stress the children, affects them epigenetically, influences the way the brain develops in terms of how the midbrain develops in terms of affiliation and attachment, how the prefrontal cortex develops in terms of executive function, and how the stress axis develops. It leads to mental health problems, but more importantly, it leads to lots of chronic illness. And so we know what the origins of chronic illness in our population is. We're, again, not addressing it. We also know that it's not just adversity that is affecting children, but this is just looking at, at the vocabulary development of children and looking at brain development. And here you see the college-educated parents versus those that were on welfare. This is an older study. But what you see is this 30 million word gap by the time children get to 36 months of age. So by 3 years of age, you see these trajectories that are developing. And what you also see is when you start to look at the brain scans that it's not just in their functional abilities, but when you look at total gray matter, you see these trajectories as well. So that what we know is that we have this enormous loss of human potential, this brain drain that's happening before the kids get to school. And so our ability of our schools to change things is limited. So this leads to a more general model, a kind of life course model, where we know that we have kids in delayed or disordered trajectories and kids that are at risk, and we know that the poverty, lack of health services, toxic stress push down on this trajectory. And if we want kids in a healthy trajectory, we have to have more protective factors. And from a population policy standpoint in communities, the name of the game is how do we reduce the number of risk factors on our population? How do we improve the number of protective factors? Because that's how we optimize health status. And so what we have currently in the United States is we have these ideal trajectories for children. Our current practice is here, and there's the opportunity gap. And you have Jeb Bush and Hillary Clinton out there talking about the opportunity gap in America and talking about it from an economic standpoint. Well, the real opportunity gap in America is here in terms of our human capital development and in the trajectories that our children are on. So we published a paper in Health Affairs back in November about the 3.0 transformation framework. And this is a framework that we developed to try to understand how do we move in a transformative way, what actually has to be transformed, how do we think about things differently. So it thinks about the healthcare system and how it's evolving. And the first era of healthcare focused on reducing deaths. It focused mostly on acute care and infectious disease. This goes back to 1850 or 1900 when life expectancy was about 40, 45 years of age. It used the new biomedical model and all that biomedicine had to tell us about infectious disease and various cures. It was focused on short time frames. It was people got sick and you tried to take care of them right away. The kinds of things that Ron was talking about, you know, if you got hit by the sickle, you had to get it sewn up right away in terms of rescue and emergent care. It's where we developed our current medical care model. It's where we developed insurance-based financing, and I'll just point out that insurance-based financing is a short-term fiscal vehicle. It's for funding things that are over a short time horizon. We built our health system based on the model that was our dominant model, which is an industrial model. That's why most of our hospitals look like big factories, and we focused on reducing deaths. As epidemiology and science changed, we entered a second era, and this starts to happen mostly around 1940 and 1950. We have an increasing focus on chronic disease. We create the National Institutes of Health, which were really the National Institutes of Chronic Diseases, and we moved to a biopsychosocial model because we start to realize from the Framingham study that health isn't just about bad luck and bad genes, but it has to do with social and behavioral issues, what you drink, what you smoke, what you eat, whether or not you exercise. And the time frames for how we manage health changed to longer time horizons. So it's no longer minutes, days, and weeks. It's actually now months and years and decades. And we changed to chronic disease management. We shift our finance from indemnity insurance to prepaid health benefits because we know people are going to have cholesterol screening and have mammograms and various other things. We move towards a corporate model of the organization of healthcare, and what ACOs are the corporatization of healthcare. It's basically how do we Kaiserfy everything in the health system and aggregate it in these corporate entities with a focus on prolonging disability-free life. And where we're headed, or where we can be headed, is towards a new era, a third era, because people are now living to be 80 and healthy, and we know what it takes for people to be 80 and healthy. We have both the scientific basis and the evidence to tell us what we need to do. And we're moving towards these life course models that tell us that if we start early, invest early, and provide the kind of protection factors, we can have populations to live to be 80 and 90 and healthy. And the fact that people are going to live to be 80 or 90 at present, and if they live to be 80 or 90 with lots of chronic disease, it ain't, that 20% of GDP will just continue to increase. And the more that we put into health care, the less we can put into education and social care and other things in our communities that we need. So that this third era is moving towards lifespan and generational notions of health care, investing in population-based health, and moving towards production models that are going to be more networked and focus on producing optimal health for all. So this is the 1.0 system moving to the 2.0 system and then to a 3.0 system. And where we sit in America today is about 1.5, 1.8 most places. Most of the European systems are about 2.2, 2.3 and moving towards this population 3.0 system. And I would argue, a lot of what we talk about and what we do is about how do we take our health system from 1.8 to 1.9. And I would just challenge us to think more broadly about how are we actually going to get to transformation, because a lot of incremental changes aren't necessarily going to get us there. It's important to think about this also in terms of what we're trying to achieve. So if you have this optimal health trajectory where we reach a certain point and then you start a downward kind of health course, I'm on the downward side of that trajectory now. I feel what gravity is like, or how it's to go downhill. And you go into a lower health trajectory, you actually become symptomatic earlier. So you become symptomatic in terms of your chronic diseases at 55 with obesity, heart disease, blood pressure problem, versus at 80 years of age. And this is what the cost curve looks like. If you go into a higher health trajectory, and by making more investments early on, you get a different cost curve. And what I would argue is that our current rallying cry of health reform, which is about bending the cost curve, is actually a fool's errand, because we're not going to be able to bend the cost curve very much. What we really need to be thinking about is how we shift the health curve in order to shift the cost curve. And that means from moving 1.0 rescue care, not just a 2.0 care that moves upstream and thinks about prevention of disease, but how do we move to 3.0 care and make those kinds of investments that we need to make early on. The Centers for Medicare and Medicaid Innovation took this 3.0 model and said, how do we look at this in terms of different ways of moving forward, going from accountable care organizations to community integrated healthcare system, and tried to lay out some of the design features of what this starts to look like. We began to think about what a transformation framework, how do we change the logic, how do we change the organization. I don't have time to go into all of this, but I'll just point to a few of the kinds of changes. So when we start to think about our logic model and what changes, our definition of health changes, not just the absence of the disease, but to a developmental health definition that looks at how do we develop capacities and realize potential. The goals of the health system is not just maintaining health and prolonging life, but it's about optimizing population health development. Client model changes from individuals, population, community. Health production model is driven by a different logic, and as you can see, this is the way that we start to design. And when we think about innovation and we think about improvement, we have to think about what are we designing for, what are we trying to improve. And so when we think about how we organize our system, this is just a little schematic that our current healthcare system are different kinds of corporate entities and certain silos, and then most of our mental health, early intervention, school health is all paid for through a different system. It's not organized and integrated, and it's very hard to organize and integrate it because it's all based on a different way of organization. So if we think about a redesign, how do we have an integrated finance mechanism that takes different funding streams, including social impact and pay for success kinds of funding, and creates an integrated kind of funding strategy? And then how do we start to design systems in which we have primary care at the center, we have primary care networks, we have primary health centers and community health workers, and that we move family resource centers and Head Start and early intervention family and school-based health centers, and we use our measurement and IT capacity to create a different kind of value portfolio. And you're starting to see this emerge in places like Cincinnati and Columbus and Milwaukee, where the children's health systems are trying to figure out how do they re-engineer and do things differently. Columbus, Ohio, the Nationwide Children's Hospital went at risk for 300,000 kids in the Medicaid system. They're now taking their AAA bond rating that they have for their children's hospital and using it to draw down HUD money so that they're working on how they're changing housing in the community and starting to think differently about how they organize and connect things up and use their data systems to move forward. So this isn't just pie in the sky kind of design, it's starting to emerge in places around the country. Now, I'm going to spend the last few minutes, because I was asked to talk about this from a community standpoint. How do we actually bridge sectors to enhance health development? This is from a conference we did at the Urban Institute with United Way Worthwhile and Kellogg Foundation. And if we're going to create a health development system, we have to have vision and goals and some kind of framework, and I think the 3.0 framework helps us move in that direction. We have to have multiple sectors and multiple levels, but we have to have cross-sector pathways and innovations that connect things up. We also have to have evidence-based and informed practices. We have to have innovations in financing, which is a whole different topic, which maybe we'll talk about in the discussion. But we have to have shared data and shared learning that catalyzes things. We won't improve unless we can learn together, and we won't have the innovation unless we can design things in a different way. So I want to talk about how do we have shared data and how do we collaborate to improve and innovate. What we've learned over the last 20 years of working in communities around system change for kids is not about the service and programs, but it's about the system. You have to embrace the complexity that you're dealing with. Communities are complex, growing, developing ecologies, and you can't think about them as sort of simple programmatic ways. You have to scale the change that's needed. Big problems and complex systems are not going to respond to incremental changes. You also have to help the system learn their way forward. Complex systems change as they're able to learn. And if you create a learning system, they will be able to change and move forward. And systems perform better. In other words, they become more resilient when sectors are aligned and produce as a network in order to move forward. We use this simplified complexity model to sort of show that in any community you have individual programs and services, so you have doctors and nurses and WIC sites and early care and education. You might have grocery stores and others that are all trying to do things to help kids be healthy and gain weight in the right way and exercise and do what they need to do. And we're trying to focus on healthy development. At the community level, you have lots of organizations, CBOs and hospitals and various other organizations. And at a city and county level, you have different city and county organizations. The funding streams make people do certain things that they do and work in certain ways, but this whole system is like a big weather system. It's like the clouds we see out there. And all this stuff is not designed to work together. It just bangs into each other most of the time, so that it doesn't function in an efficient way. And so what we are looking towards is sort of how do we begin to align the city and county departments? How do you get the community-based organizations to actually function as a network? And how do you get integrated pathways that actually work for families and communities? So you have to have some kind of learning system for collective impact that allows these different levels to work together and allows you to have the kind of horizontal integration that moves forward. So we have come up with this model that we use in communities around the country where you have lots of different programs in any community, but how do you sort of make them work together? Because a family that might need all these programs also needs a social work degree and a civil engineering degree to actually figure out how to make them work, because they weren't designed by Steve Jobs in a user-friendly way. They were designed basically to bang up against each other. And so how do you align these sectors to work together? You have to have a common agenda and have a common focus. So we use these trajectories and health trajectories or developmental trajectories to bring together, because the health sector gets it, social service gets it, education gets it, family support gets it. We have to have some kind of shared outcome that everybody's working towards. You can't have health working on health and education working on education. What is the common thing that brings us together for the commonwealth of the community? We have to have some kind of way of learning together and some kind of financial and alignment. So we've been doing in communities is we've been trying to link information so we can actually measure trajectories. And we've been measuring in communities something called school readiness or healthy development using a tool called the EDI. The EDI is used in every community in Canada, in every community in Australia. They measure all 300,000 kindergartners every 3 years in Australia to see if they're healthy and developing and starting school in the right way. What the EDI does is it measures the social competence, emotional maturity, language development of kids, their physical health and communication skills. So it's a health-related quality of life of a 5-year-old. And what's important is it's really a sentinel indicator of how these children are going to do over the long term. We take that data and we map it to neighborhoods, and not just to zip codes, but neighborhood by neighborhood, so neighborhoods can sort of see what they're doing. So this isn't the county health rankings that you're looking at a whole county. This is Orange County, California, but you're looking neighborhood by neighborhood so that neighborhoods can see where they're at. We are able to map poverty, crime rates, all kinds of other things, so the police can see how they relate to healthy development of children. Housing can see where they relate, how the social service programs. So it's about creating that issue of understanding how the community can support well-being. And we've been working around the country with this initiative called TEXT, where we're trying to bring this kind of alignment and integration strategy so we can improve in performance. What we do is we engage communities around collecting data and moving towards planning for community-wide interventions, working at a neighborhood level. We do measurement, mapping, and analytics with the communities, or they do it themselves. We support it with targeted systems improvement, and we have a national learning system. We're working, it's spread very rapidly over a 3-year or 4-year period from 10 sites to 50 sites around the country. And this is just a couple examples of what the sites are doing. This is Pasadena, California, where they map their EDI data in green in the more vulnerable versus less vulnerable, and you're looking here at poverty rates in these communities. And what the city of Pasadena and their city council did is they said, gosh, our children aren't doing as well as we thought, and they're not doing as well in the rich areas and in the poor areas, and we need to do something different. So Pasadena passed an early childhood, or created an early child development policy. They created a master plan for early childhood in their community. And what they're doing is they now have an Office of Early Childhood in the mayor's office. Same kind of thing is now happening in Hartford and several other cities. So they're using data to change policy at the top level of that diagram. So they're bringing the different parts of the city together to work in unison to try to work together. Second place I want to show you is the Magnolia Community Initiative. And Magnolia is in Los Angeles. What they're trying to do in Magnolia is make sure that all 35,000 children living in this part of LA are thriving. They could have built a couple of educare centers where they would be taking care of 300 or 400 kids really, really well, but they said, how do we work at scale? And so you see on the right there a kind of ecological model that they're trying to figure out how do they bring everything together. They've created 6 hubs in the Magnolia area to serve children and families. There's 71 partner organizations. There's 100 community groups. And there are 500 block advocates that are being created through a community organizing way there. And there's 14,000 families. And what is happening is these different community-based organizations and parent groups are coming together and trying to learn together and create a learning system. We're mapping the EDI in dark green. Here's social competence of children. The more vulnerable are the darker green. And here's maternal depression risk. This isn't at a county level. This is neighborhood by neighborhood. So we can have mental health, early care and education, health, everybody coming together and saying, what do we do in this neighborhood? We have 25% of the mothers depressed and the kids aren't thriving. How do we actually change it in this neighborhood, not just in general? And so we're working on community solutions there. This is looking at reading to children and the like. And Magnolia, they've created driver and logic diagrams and ways of thinking about how they're going to support and manage change, thinking about how do they support parents and how do they make the change strategies work. And they're using care processes and system function and population outcomes and dashboards. And we're using all the same things that you would use within a hospital, that IHI or Breakthrough Series kind of collaborative improvement. We're taking this into the community and creating the same kind of learning system so these communities can move forward. And so what we've done is we've gone back to this community model. We've tried to figure out how do you create alignment strategies in communities? How do you create community initiatives that try to bring this together? How do you have strategies and logic models that bring that together so that you can have the kind of 3.0 or 2.5 kind of community-based networks that are actually working together as a network? How do you use data and analytics to get everybody on the same page and working in the same direction, not at a county level or city level, but actually at a neighborhood and community level and across systems? And then how do you use outcomes management and learning systems to actually drive the process? Now, I'm not going to have time, because I'm almost out of time, to talk about the Child Health System Transformation Initiative. Let me just briefly say that part of what we're trying to do with this initiative is figure out not only how we go from 1.0, focus on persons and just on the hospitals, or a 2.0 system that's thinking more about the whole person and trying to integrate, but how do we get to a 3.0 system for children, not just in one community, but in 1,000 communities across the United States. And so we're starting to work with the Robert Wood Johnson Foundation, Kresge Foundation, the Doris Duke Foundation, to put in place the kinds of strategies through something that we're calling CHSTI, the Child Health System Transformation Initiative, which is a bridge between 2.0 and 3.0. We're trying to create a national learning network and getting communities to commit that over the next 10 years, they're going to have the healthiest children in the world, not be number 30th out of 30 nations. And we have communities like Milwaukee and San Diego and Hartford and Columbus and Cincinnati, and I'm sure that Denver and Glenwood Springs and Grand Junction could be part of this as well. But what we're doing is trying to create the learning environment, networking tools, and design features that allow us to join together and move in this direction. So CHSTI is all about trying to optimize the health of all children and to work in ways that will create a national learning community focused on using innovation dollars out of CMMI and foundation dollars and bringing that together so that we can have real transformation that takes place. And I will, there's more to say about CHSTI and how we're moving it forward. Let me just close by mentioning one thing because it might be of interest to you. There's another project that's part of CHSTI called Moving Healthcare Upstream. What Moving Healthcare Upstream is trying to do is how can we address a whole set of issues that we're addressing in our healthcare system, of how can we address personal and family situations and stressors in a better way? How can we help families move in the right direction? How can we help neighborhoods and communities move in the right direction? How can we align the resources in communities? And what Moving Healthcare Upstream is trying to do is come up with a set of cross-cutting kinds of approaches that work not just for asthma and early childhood or maternal depression, but work for everything and that affect families. And there's a whole logic model to that. But one thing I just want to point out is that we're in the process of creating a national learning network for Moving Healthcare Upstream, and there's an RFP out on the street from Kresge Foundation to invite communities into this national learning network that want to be part of a way of moving to empower and activate communities and actually try to move towards some of these 3.0 goals. And so that if you're interested in this, you can talk to me about this, because it allows communities here in Colorado that might be interested to potentially participate. And also, if you're interested in the CHSTI or TEX initiative, I'm happy to provide additional information. So let me stop there, and conclusions quickly. We have a new science of life course health development that provides a powerful new framing to move towards 3.0. We have this 3.0 transformation framework that designs for transformative strategies. We have these several different initiatives that are actually trying to move towards 3.0, and the focus is not putting all the transformation focus in the healthcare system, but it's about bringing communities together so that they can work on this together. Thanks very much.